Hi, everyone. Today we're going to talk about care of the patients with acute coronary syndromes. Here's our learning objectives. The etiology of coronary artery disease. Atherosclerosis is the primary factor in the development of coronary artery disease. Another etiology for coronary artery disease is metabolic syndrome. You can see a complete list of the trifectas that can cause metabolic syndrome, or sometimes called X syndrome, on page 771 in table 38.1. But basically, it's people who have had a sedentary lifestyle, increased cholesterol, obese, especially with abdominal weight. They can have uncontrolled diabetes. They can be a smoker. All of these things are leading factors that can be a part of the trifecta of metabolic syndrome. And the entire list is there for you on page 771. But they have discovered that anytime that someone has three of these litigating factors, they also have metabolic syndrome. Now, some of the risk factors for coronary artery disease and also for metabolic syndrome at the same time are modifiable. We can decrease our serum cholesterol by taking medication or changing to a heart-healthy diet. We can alleviate cigarette smoking. We can control our hypertension, whether it's by diet or exercise, taking our medications routinely, and making sure that we keep that blood pressure less than 130/80. Now, I don't want you to think when I say that you can modify the risk factor of diabetes, what that really means is once you have diabetes, whether it's type 1 or type 2, you always will have that diagnosis. But what you can modify is, let's take a type 2 diabetic. If their blood sugar is not under good control, they can get that blood sugar under control, whether it's with medication or diet and exercise. They can lose weight. That will also help to get that blood sugar in control. A lot of times when people have lost weight, they can either decrease or eliminate taking their type 2 diabetes medicines. A lot of times that will be enough with just proper diet and exercise. I think I just spoke with obesity along with the type 2 diabetes. You can alleviate excessive alcohol. And when we're saying here the limited physical activity, it's saying that if you have a sedentary lifestyle, starting to become more active will decrease the risk factor, which is having a sedentary lifestyle. So the more active you are, the less likely you are to get coronary artery disease. And sometimes we can't alleviate our stress, sometimes we can. But if we can't alleviate it, it's really, again, it's about being able to control your emotions with the stress or how you cope with the stress. Whether you go with psychotherapy, learn meditation, learn how to, other ways to release your stress, whether it's through exercise or painting or screaming. But all of those are modifiable risk factors. Now, some of our risk factors are non-modifiable. Age, the most important risk factor for developing coronary artery disease in women is age. Now, gender. Men have their first MI earlier than women, but by age 70 by age 70 and older, the incidence of MI is equal. Family history. Does your family have a history of coronary artery disease? An ethnic background. African Americans and Hispanics are more likely to develop coronary artery disease. And those are risk factors that are uncontrollable. So, in case you think Ms. Ritter got confused, why is she talking about coronary artery disease? And that's because coronary artery disease is a broad term, including both chronic stable angina and chronic coronary syndromes. Coronary artery disease is the single largest killer of men and women in the United States. It is the leading cause of premature and permanent disability in the United States as well. So, as I said before, coronary artery disease is a broad term. It includes both chronic stable angina and the acute coronary syndromes. When coronary arteries are diseased, the heart cannot pump blood effectively enough to perfuse vital organs. Now, there's a difference. Ischemia is when it's insufficient oxygen supply to meet the requirements of the pericardium. Infarction is necrosis and death, when that ischemia becomes severe or prolonged and you have decreased perfusion causing irreversible damage to tissue and tissue death. So that's the difference. So ischemia is an insufficient blood supply, but infarction is when you actually have necrosis and cell death and tissue death. Okay, the first one we're going to talk about is chronic stable angina. Now, this is not someone who is having angina for the first time. This is someone who has chronic angina. This means that their chest discomfort or pain happens after moderately prolonged exertion. And remember, this is exertion for them, in a familiar pattern to the patient. So a lot of times people with chronic stable angina will know, I really should not have tried to walk up the stadium steps. I knew that was going to cause me to have chest pain, but I was able to control it with resting and taking my nitroglycerin. Sometimes people will say, I should not have tried to mow the entire yard. I know to stop halfway through because it is their familiar pattern. When it's the familiar pattern, it is the same frequency and duration and intensity, and the signs and symptoms remain the same. This is important because if the patient's pain is different, that it is not their chronic stable angina. They have slight limits to their activity. Most of the time, the patients can have like a workaround. They know that they're going to have an episode of angina if they try to, let's say, mow the whole yard. But if they stop halfway and rest for 45 minutes, they won't have it. They know that walking from the bottom of a parking lot to the store is too far, so they have received a handicap sticker where they can walk from just a smaller, easier parking place. It is also always relieved with nitroglycerin and or rest, and it generally does not last over 15 minutes. So that's your chronic stable angina patient. We are now going to talk about acute coronary syndrome. When an atherosclerotic plaque in a coronary artery ruptures, causing clot formation and vasoconstriction, that is what can lead to acute coronary syndrome. But now the amount of disruption of the plaque determines the degree of coronary artery obstruction or the blockage and the specific disease process. So it's not the atherosclerotic plaque that's the syndrome. It is how much of that coronary artery is occluded, and that helps to determine what the specific disease process is. Keep in mind that 40% of a coronary artery has to be blocked in order for you to have any type of pain or disruption in your coronary blood flow. The most serious acute coronary syndrome is a myocardial infarction, and that will be covered in detail in 495. Unstable angina. This is chest pain that occurs usually with exertion, but sometimes at rest, and that's when it's caused from a coronary spasm. Activity is limited, but it's only mild to moderate. It's not severely limited. The big thing with unstable angina is that the pressure does not last longer than 15 minutes, and is relieved with either rest or nitroglycerin. Now, the difference here, you're going, what do you remember? That's what you just said about stable angina. The difference is with unstable angina, this is the first time that the patient has had this particular type of chest pain or the unstable angina. So again, it's the chest pain that occurs with usual exertion, but sometimes it can happen at rest with a coronary spasm. There are different types of this disorder. There's the new onset of angina. This is the first angina symptoms, usually after exertion or other increased demands on the heart. The other is the variant angina. Now, this is chest pain that I was talking about when it was at rest. That's usually caused from a coronary spasm. Lastly, it's the pre-infarction angina, which is chest pain that can occur weeks or days prior to the MI. This sometimes is pre-infarction angina kind of will start to potentiate and get worse as that week progresses. So, how do we know when it's the first time that a person's having chest pain that it is unstable angina? Well, an MI must be ruled out first. So if a patient is having chest pain, or a person in that matter is having chest pain, it is important that we rule out an MI. And that means if we are in the community, that we call 911 and have them taken to the emergency department. If we are in the facility, then we're going to want to do a focused assessment. We're going to want to look at their pain, when they where their pain is, where its location is. Does it go down their arms? Is it crushing? Does it go into their jaw? You want to make sure that you do a rhythm strip. And if they're on a regular standard floor, this would be the time when you would call the rapid response team. You would, so that they could perform a 15-lead EKG, see if there's any changes. Are there associated symptoms? Nausea, vomiting, diaphoresis, dizziness, weakness, shortness of breath, palpitations? Does the patient have a history? Again, if they normally have stable angina and they go, this doesn't feel like my normal chest pain, you need to go ahead, start that rapid response team so that we can see if it is different. Most of the time, your patients know, especially your patients who have coronary artery disease and have stable chest pain or stable angina, they will tell you, this isn't my normal. This isn't my radio. We need to, to help with that. We need to know what medications they already take, what they have already tried to do to relieve that pain. And you want to make sure that you get IV access in that patient if they don't already have it. Now, on the next set of slides, I'm going to do a brief overview of myocardial infarction.